τελικά δεν είναι ένα σπάνιο νόσημα. Και πλέον έχουμε εγκαταστήσει τη μέθοδο προσδιορισμού του RNA του ιού στο εργαστήριό μας. Και τελικά η διάγνωση και στους όλους αυτούς τους ασθενείς ήταν οξέα υπατήτηδα ε. Άρα θα πρέπει να θεραπεύουμε τους ασθενείς και όχι το εργαστήριο. Τελειώνω με τα μηνύματα ότι η αυτοάνωση υπατήτηδα δεν είναι ένα σπάνιο νόσημα. Αφορά όλες τις ηλικίες και όλες τις εθνικότητες. Μπορεί να προσδιοριστεί με οποιοδήποτε τρόπο, άρα θα πρέπει να μπαίνει στη διαφορετική διάγνωση όλων των ασθενών. Θέλουμε έγκαιρη διάγνωση για να αποφύγουμε την εξέλιξη της νόσου. 1/3 των ασθενών των ενηλίκων και μισή από τα παιδιά έχουν κύρωση ήδη. Η κλινική εικόνα δεν είναι χαρακτηριστική για την νόσο, άρα θα πρέπει να την υποψιαζόμαστε πάντα. Είναι πολύ σημαντικό να αναζητήσουμε τη συνύπαρξη αυτοανώσεων νοσημάτων και συνδρόμων. Δεν υπάρχει κάποιο χαρακτηριστικό από το βασικό εργαστηριακό έλεγχο των τρανσαμινασών και της χολερυθρίνης. Οι τρανσαμινάσεις μπορεί να είναι ακόμα και πολύ λίγο αυξημένες και φυσιολογικές, αλλά είναι πολύ χαρακτηριστικό η αύξηση IgG, της οποίας οι φυσιολογικές τιμές μπορούν να. Ωστόσο, οι φυσιολογικές τιμές δεν αποκλείουν την παρουσία της νόσου. Έχουμε τα αντισώματα που περιέγραψε ότι θα πρέπει να γίνονται με βάση διεθνή στάνταρτ και υπάρχουν ειδικές τεχνικές για τον προσδιορισμό των αντισωμάτων. Η βιοψία είναι απαραίτητο να γίνεται όταν μπορούμε να την κάνουμε. Όλοι οι ασθενείς θα πρέπει να θεραπεύονται εφόσον υπάρχει ενεργός νόσο. Η θεραπεία θα πρέπει να εξατομικεύεται και εφόσον δεν υπάρχει ανταπόκριση, δύο πράγματα συμβαίνουν. Ή δεν βάλαμε καλά τη διάγνωση, άρα ήταν κάποια άλλη διάγνωση, ο ασθενής δεν συμμορφώνεται με την αγωγή. Ευχαριστώ.
Ευχαριστούμε τον κύριο Gatselis για την εμπεριστατωμένη ομιλία. Ο χρόνος είναι αμήλικτος και προχωράμε στον επόμενο στρογγυλό τραπέζι. Ευχαριστούμε πολύ. Okay.
Αυτή τη στιγμή στο Αμφιθέατρο Ιπποκράτης μπορείτε να βρείτε τις ομιλίες σχετικά με τη διαχείριση της χρόνιας συγχμωρίτιδας, καθώς και για το ATLS, που είναι ένα must για κάθε νέο ιατρό, από δύο προσκεκλημένους ομιλητές, οι οποίοι είναι διακεκριμένοι στο εξωτερικό, τον κύριο Rautiainen Markus και τον κύριο Wagner Christof.
Dear medical students, dear young doctors, it's a great honor for me to present you Markus Rautiainen. Markus Rautiainen is the professor of photolaryngology at the University of Tampere in Finland, and he's the chairman too of the Department of Photolaryngology and Oral Diseases of the University of Tampere in Finland. His main interest is related to rhinology, and as a result has had many scientific pioneer certification in this field. Also, Markus Rautiainen is responsible for the training and education of medical students of the University of Tampere. Dear Markus, welcome, and please come to the stand.
Okay, dear Professor Pisakis, and dear Chairman, and dear ladies and gentlemen, it's the first time for me to attend the meeting or congress organized by the students, but the idea sounds very interesting. Maybe I bring it with me to Finland too. Okay, I changed a little bit title so that I'm going to talk about the management of the sinusitis. And the reason for that is that before, I think so that most of you are students, and before you will be the ENTs, you will be GPs, and there you need the knowledge about acute sinusitis and the beginning of the chronic sinusitis and the surgery and that kind of things are not so important for you. And actually, it has bigger effect on the health than what has this special healthcare and this operation and how we do what we are doing to the patients. So I'm coming from the Finland, and there is that Red Cross. It's in the Tampere. Tampere is in the southern part of the Finland, and the second biggest city in Finland. No, I cannot use this. Yes. Okay, why sinusitis? Why it's important for the GPs? It's very important because it's so common. And most of the patients with sinusitis are in the active age. They are not old people. They are not very young children usually. They are usually young adults. They are students and others who are working. And the pill of sinusitis it's a really big money what we are using for the treatment of the sinusitis. There are a lot of medications, a lot of antibiotics. We are doing quite a lot of. It's one of the most common operation, sinus surgery, and also the number of sick leaves because of acute sinusitis it's a huge, and that's why it's very important for us. And to treat sinusitis, we have this kind of European position paper of management of sinusitis and rhinosinusitis, and also in Finland it's that kind of European paper, and I think that it's also somehow accepted here in the Greece. It's also used in the Finland, but we have our own domestic guidelines for the treatment of sinusitis, and they are very close to that EPOS, but have some minor differences. And why we need these guidelines is that if we are following the guidelines, we can do better diagnosis. We can decrease the use of antibiotics. We can decrease the use of operation, and total cost of the treatment of the sinusitis will be decreased. Also, if we follow the guidelines, we will use more adequate examination, and we will give a better treatment for the patients. Yeah, now I found the button. Yes. Okay, now it's when I was a student and a young doctor, the definition of sinusitis was very easy. That if there was pus in maxillary sinus, then we call it sinusitis, and everything else was something else. It was we didn't have even a name for that. But nowadays it's quite complicated, and in this European guidelines, it's coming a diagnosis for the acute rhinosinusitis coming from the 2 or more following symptoms: nasal obstruction, rhinorrhea, and facial pain or feeling of the pressure, olfactory disorders, and cough. And also some findings in endoscopical findings, polyps. That means it's not anymore acute. If we see polyps, it's a chronic sinusitis. But secretion in the nose or in hypopharynx, mucosal swelling. And also we should have some findings in X-ray. And usually nowadays we are using more and more, not this kind of native X-ray that in Finland we are mainly using. In primary care a little bit this traditional X-rays, but in the southern part of Finland mainly CT scans for the diagnosis of sinusitis. The guidelines advise us also to estimate the severity of sinus and sinusitis symptoms, and for that they recommend to use visual analog scale. And it's in primary care, it's what you are doing there in primary care. You have to first, when you are doing the diagnosis, you have to think that is it acute or chronic sinusitis. And if the symptoms, if the patient has symptoms of less than 3 months, then we call it acute sinusitis. And if the symptoms persist, then we start to speak about chronic sinusitis and doing more detailed examinations to the patients. Traditionally, we think so that it's a sinusitis is an infection. Also, the name of the sinusitis sounds infection, but actually, they are not. Mostly, it's not bacterial infection. So that 95% of the acute sinusitis is the viral infection, and bacteria are coming much. They are coming quite seldom and later usually. However, we are treating most of these sinusitis patients with antibiotics. I don't know how it's here in Greece, but in Finland, it's so. And when you are doing the diagnosis there, so it's somehow you try to differ first that is it common cold or is it rhinosinusitis, and if it's a rhinosinusitis, is it viral rhinosinusitis or is it bacterial rhinosinusitis? And why we have to do it? Because GP, he has to decide that if he's giving the symptomatic treatment or antibiotics. And it's if we just are listening to complaints of the patient, it's very difficult to say. Even the severe complaints, they cannot identify acute bacterial sinusitis. There was just a couple of years ago, it was published, it was a follow-up study about acute sinusitis. They were following from the moment of the diagnosis 2 weeks the patients, and they were taking 3 times CT scans from the patients, and they were following what's happening to the patient, and they noticed that the symptoms are, it's almost impossible to decide if you are listening only to symptoms that if the patient have acute bacterial or virus sinusitis. So that's why symptoms, of course we have to ask the symptoms for the patient, but then we have to do accurate clinical examination, and that means that we have to do anterior and posterior rhinoscopy. And it's very important because if it was the same study, they showed that if you can see secretion in the nasal cavity or in the nasopharynx, then the probability of bacterial rhinosinusitis increased markedly. In Finland, we are also using, to show the secretion in the maxillary sinus, we are using ultrasound, but I guess so that all over the world they are not using this kind of method. And it's somehow it's not very reliable study. In acute rhinosinusitis, I think that we don't need any X-rays. And this is some kind of schema about how to treat sinusitis, so that in the beginning we don't need antibiotics, and we should just give a symptomatic treatment. But if the patient continues to have symptoms over 1 week, over 10 days, then we have to consider if we should use some topical steroids and consider if we should use some antibiotics. And if the symptoms are still persist and if they are severe, then we have to start to think that should we take X-ray. But also if we can see in X-ray, we can see secretion in the maxillary sinus. According to, it's the same group at a different study. They show that only 40% of the patients who had secretion in maxillary sinus, they had a positive bacterial culture of the aspirate of that sinus secretion. So that the probability that if we see in X-rays, if we see that there is a fluid level in sinus, probability that it's bacterial infection, it's only about 50%. Okay, what is symptomatic treatment? And it's maybe in Finland, the decongestants, they are most used. We are using quite a lot of also saline irrigation, but I think that in the acute phase of the sinusitis, it's useless. I think that the saline irrigation is better for the treatment of chronic sinusitis if you have secretion in the nasal cavity, and if the patient is operated, then it's also possible to irrigate maxillary sinuses. Then, if the patient have very persistent symptoms, then also maybe the topical corticosteroids is a treatment. But what is very good is the painkillers, rest, and time is very good in the treatment of acute rhinosinusitis, because most of the patients will recover without any treatment. Okay, if the patients, if they will have very persistent symptoms, then we have to start that to be add topical corticosteroids to the treatment. It's not very effective, so that you have to use several days of those, and you have to use every day those topical steroids to get some help from those. But if the symptoms at this time, if they are very severe, then I think so that even we don't know if the sinus is bacterial or not, then we should use antibiotics. But I think so that most of the patients, if we follow from the beginning, have recovered before this phase. And if we don't get any effect with antibiotics, the corticosteroids, then we have to start to think that should we have imaging, should we take the X-ray, or in Finland we are usually thinking that should we do the maxillary sinus puncture. We are still using it quite a lot, but I know that all over the world they are using nowadays. They are not using maxillary sinus puncture, but it's very helpful if there is a secretion and if you irrigate the sinus, then the relief comes very quickly after irrigation. We are doing that also in primary health care, and most of the students, medical students, learn to do it during the education. Also, if the symptoms are very severe in this phase, you have to refer to ENT specialists. And if these symptoms persist for a very long time, then you have to think also that do you have correct diagnosis? Also, this temporomandibular joint dysfunction and pain is sometimes it's very similar with these sinusitis complaints. Also, this pain and feeling of the pressure, they may be the dental origin. If the sinusitis is unilateral, then we have also to think that is there tumor, papilloma, or is it the dental sinusitis. This is this coming from the EPOS. It's about the same what I was explaining you before, that it's some kind of schema, how we should take care of the rhinosinusitis in primary care. And it's also very important to know, especially if you have pediatric patients, then if you will see if he has a severe rhinorrhea, and periorbital erythema or edema, then you have to be very careful that it may be the sign of orbital abscess and have to be treated immediately. In our hospital, we have those cases, maybe 5 or 6 in 1 year. But it's university hospital. It's not common, but you have to know it. Okay, then let's go to the chronic sinusitis. If you see polyp in nasal cavity, it's always chronic sinusitis. So there is no acute polyps, and it's the sign of the chronic inflammation. And the chronic sinusitis is also, it's complicated. It may be that kind of chronic sinusitis you have all the time secretion in the sinuses. It's not only the maxillary sinus, you have also ethmoiditis, you may have also sphenoidal sinusitis. It's much more difficult to diagnose, but however, there may be the persistent symptoms and complaints, but it may be also, chronic sinusitis may be also so that patients have the feeling that he has a repeated acute sinusitis. If those you have in 1 year more than 4 or 6, then you have to start to speak about chronic sinusitis. And then if we think that what examination should we do? If we think this is the first time when we need X-rays, and if CT scans are not available, then this native X-ray is also a very good start. But usually, if we see something in native X-rays, then we have to follow it with CTs. MRI is not very good examination for sinusitis. And here is on the right side there is a CT scans, on the left side is a native X-ray, and it's very easy to see that the information in CT scan is much more. It's 10 times or 100 times more than what we can get from these traditional X-rays. This is a scheme, some kind of schema also for ENT specialists, how to treat the patients with chronic sinusitis. And also there is in the beginning, when we start to think that should we make an operation, we have X-rays. The first step is, however, to test that could we treat using conservative treatment, and that means topical corticosteroids. And if the patients are using those regularly, more than 1 or 2 months, it's almost half of the patients get clear relief to their symptoms, and some patients don't need any operation of that. So it always should be tested before we start to plan operations. Nowadays, in the old times we were doing that kind of radical sinus surgery. We were removing all the mucous membranes and making a very big holes to the sinuses. But nowadays the aim is that we try to preserve the anatomy of sinuses, preserve the mucous membrane, and we try to little bit widen these ostia and to get the better ventilation to the sinuses. We try to restore mucociliary clearance, but it's more complicated. I think that by the operations you can make all kind of operations there, but it's really difficult to restore the mucociliary clearance because the inflammation still remains after operation. The inflammation still remains to the mucous membrane, and that's why the mucociliary clearance in chronic sinusitis is very poor. Nowadays there are two kinds of operations. Main operations what we are doing in the case of chronic sinusitis, and most used, and now it has been used for 25 years, is endoscopic sinus surgery. it is called also FES. Previously it was called functional endoscopic sinus surgery, but nowadays we know that it's not very functional. However, there is not any standard endoscopic sinus surgery. It's very much up to the patient, and it should be always targeted only to the pathology of the sinuses, not to do very big holes to every an ostia to every sinus. It's only we should operate those sinuses, those are affected and those have inflammation. And when we enlarge the ostium, we will get better ventilation there, maybe better drainage, and it's also, after the operations, these patients, it's also possible to irrigate those sinuses. Here for CT scan from the patients, from the left to first, they are unoperated patients, and two scans on the right side, they are operated patients. That patient is only the one side is operated, but the other side is not operated. But here, these patients have undergone very radical endoscopic sinus surgery. Nowadays, there is quite a new method, balloon sinuplasty, and it's not any operation. It's there we introduce a thin catheter to the sinuses through the ostia, and with balloon we dilate the ostia area, and it's very atraumatic. Always we will get a little bit bleeding, but however afterwards it's impossible to say if the patient has a balloon or not. But it's these two methods, they are not concurrent methods for the treatment, and endoscopic sinus surgery still nowadays it's the most used method and should be most used method. But for sinuplasty we have also used, if we have mild rhinosinusitis, if the radiological findings are very minor. Also the frontal area is very good target for the balloon operations. It's much less invasive, but the cost of these balloons, it's nowadays maybe 700 to 800 euros, so it's much more than what we get from the endoscopic sinus surgery. But we need much more studies to find out if it's effective or not, or how effective it is. In our department, we made one, actually it's an academic thesis, but one doctor, female doctor, her name happens to be Argiro Pisaki, and maybe the relative to the chairman. But in her study, he showed that both balloon sinuplasty and endoscopic sinus surgery improved the quality of life of the patients with chronic, very mild rhinosinusitis without any very major pathology. So they were very equal way to treat the patients. But if we have polyp, if we have clear major pathology in the sinuses, then we have to always use endoscopic sinus surgery. And in our department, I think that we are using this conventional endoscopic surgery for over 90% of the operations. Okay, as a summary, I would like you to remember that most cases of acute rhinosinusitis are viral infection, and the treatment for that is symptomatic treatment, not antibiotics. Also, the treatment of chronic sinusitis should be started with topical steroids, saline irrigations, and the surgery is the last step for the treatment. And we have to remember that if we are doing surgery, so about 50% of the patients after surgery will recover almost totally. But then 40% of the patients, they still will have some problems, but some way the quality of life is better. And there is about 5 to 10% of the patients who don't get any benefit for the from the surgery. And this, especially the surgeons very often don't remember. And the take-home message is that sinusitis is mainly an inflammatory disease or mucous membrane. It's not anatomical disorder, and it's not bacterial infection. And here's the nice scenery from the Tampere. Here it's in the summertime. Sometimes we have very good weather, but yesterday it was still snowing there. And maybe it was a little bit different. Thank you. Yeah. Thank you for your attention.
Professor Markus Rautiainen, thank you very much for your presentation. I think it's turn of Professor Malizos to present the next speaker.
Έχω την χαρά να είμαι συμπροεδρεύων με τον κύριο Μπιζάκη, τον οποίο είμαστε μαζί περίπου μισό αιώνα. Μισό αιώνα, σας κάνει εντύπωση. Στη δεύτερη εφηβεία μας είναι μισό αιώνα. Λοιπόν, και ο καλεσμένος μας, ο επόμενος, είναι ο καθηγητής κύριος Wagner. Ο Christof Wagner έχει βρεθεί στο αμφιθέατρο αυτό αρκετές φορές. Έχει επισκεφθεί την ιατρική μας σχολή και έχει δώσει διαλέξεις πολλές φορές επίσης, και είναι ένας πολύ καλός πρεσβευτής της ιατρικής μας σχολής. Δεν πειράζει, 2 λεπτά είναι. Είναι καθηγητής, όπως είδατε, της χειρουργικής του τραύματος και ο κατεξοχήν κατάλληλος να μας μιλήσει για το ATLS και την αναγκαιότητα μετά από τη μακρά εμπειρία του. Κύριε Μακαντάση, δεν έχουμε εικόνα. Μακρά εμπειρία να μας μιλήσει λοιπόν για την σημασία και την χρησιμότητα του ATLS για εσάς τους νέους γιατρούς. Γύρισα το λίγο, ναι. Ήθελα να δείξω 2 διαφάνειες μονάχα. Έχει υπάρξει λοιπόν ένας πολύ καλός πρεσβευτής στην Γερμανία και στη διεθνή επιστημονική κοινότητα του έργου που έχει γίνει στη δική μας ιατρική σχολή. Εδώ η φτωχή ποιότητα της οθόνης δεν αναδεικνύει ίσως αυτό που θέλουμε, αλλά φιλοξενεί σε αρκετές διαφάνειες Έλληνες με τον δικό του παραδοσιακό τρόπο, με ένα βαρύ ποτήρι μπύρας, οι οποίοι έχουν υπάρξει ως επισκέπτες οι νέοι γιατροί, visiting fellows, σε ένα πρόγραμμα για τις χειρουργικές λοιμώξεις. Το ιδιαίτερο πεδίο του ενδιαφέροντός του είναι οι χειρουργικές λοιμώξεις, για τις οποίες μιλήσαμε στο φόρουμ αυτό πριν περίπου 2 ώρες σαν το Biofilm. Έχει υποστηρίξει Έλληνες, είναι παιδιά από το Πανεπιστήμιο της Αθήνας, απόφοιτοι, που σήμερα κάνουν ειδικότητα στη Γερμανία. Έχει υποστηρίξει δικούς μας ειδικούς και ειδικευόμενους επισκέπτες για επιστημονικό λόγο, εννοείται, και όχι για τουριστικό λόγο, στο τμήμα του, και φυσικά έχει πλαισιώσει τη φιλοξενία, όπως σας είπα, με την κατάλληλη κοινωνική δραστηριότητα και τις κατάλληλες εξόδους. Η Χαϊντελβέργη, που είναι και η πατρίδα του, τώρα εργάζεται στο Ingolstadt, είναι ο τόπος που γίνεται το διάσημο Oktoberfest και εκεί και στο Μόναχο, και θα είναι αύριο ομιλητής σε συνεργασία με μια απόφοιτο του δικού μας πανεπιστημίου, την κυρία Αναστασοπούλου, και έναν απόφοιτο επίσης της δικής μας σχολής που τώρα είναι ειδικευμένος ορθοπαιδικός, τον κύριο Καρά, και εργάζεται μαζί του στο Ingolstadt. Είναι λοιπόν ιδιαίτερη τιμή να φιλοξενούμε τον φίλο της ιατρικής μας σχολής και θέλω με αυτό να τον καλέσω εδώ. Dear Christof, it's a privilege for me to host you. I hope after so many visits you understand some Greek. That's the reason I announce you in Greek. Uzo, yeah, for sure. So please take the podium. It's yours. Έκανε μια ηρωική προσπάθεια να είναι εδώ, γιατί χθες του κλέψανε τον υπολογιστή από το πρώτο μπαγκάζ του αυτοκινήτου του στην Αθήνα. Και παρόλα αυτά καταφέρανε να συναρμολογήσουν τα απαραίτητα με τη βοήθεια για να είναι σήμερα εδώ συνεπείς. Ευχαριστώ. Thank you, Christof. Good job.
So, Kostas, thanks very much. Dear Kostas, dear Chairman, dear colleagues and friends. Now, first I want to thank the organizers for inviting me to this wonderful and sunny Greece, and especially to, as you heard, to Larisa, where I run a visiting professorship since 2011, working with Kostas Melitsas. It's a great pleasure for me. So, to introduce a little bit myself, I did my medical studies in Heidelberg, in London, and also in South Africa, in Cape Town. And now, currently, I'm running a position as a consultant trauma and orthopedic surgeon in Ingolstadt. This is a small town located in the south of Germany, world famous for Audi, although I prefer to drive a BMW, of course. It's an academic hospital which belongs to the University of Munich, which is in the south. Here, it's 60 kilometers south from Ingolstadt. And you know, and you have seen these pictures well known from the Oktoberfest, and you see you can have a lot of fun. Now, I'm also running a position as a professor of surgery and traumatology at the University of Heidelberg, which is the oldest university, 630 years the last year. It's a very romantic town. And this university is well known for his university prison, which we call a Casa, because according to the former jurisdiction of the university prisoned, for example, lazy students or sleeping students in this prison. Now, I'm not only a professor, I'm also a student, so I know how you feel when you go to exams. I also have to pass exams because in my spare time, I'm a student of medical law in the International University in Dresden, which is in the eastern part. So being a professor and being a student at the same time, I know that learning is a continuous ongoing process, especially when you are a medical doctor after passing your medical exams. And one of the most, and I think the best programs in the world for doctors is the Advanced Trauma Life Support, ATLS, and I'm very happy to be one of the German directors for ATLS, and I'm primarily responsible for this military hospital in Ulm. Now, what is ATLS? ATLS is an emergency room management of multiple severely injured patients. This means patients with life-threatening injuries. And let's see this case, 25-year-old male with a road traffic accident. Now he is suffering a head injury with a skull fracture, subdural hematoma, contusions, severe maxillofacial trauma, thoracic trauma with tension pneumothorax, a blunt abdominal trauma with a spleen rupture as seen here, a pelvic fracture, a spine injury, and also a fracture of the right femur. So the question is how to manage such a complex patient with several life-threatening injuries. And the simple solution is ATLS. So maybe you can think that this is a must for a traumatologist or maybe for a surgeon, but the question is it a must for every young doctor? And as a young doctor, you can argue, I'm a traumatologist, I'm a surgeon, so it's not a problem for me, I will save him. But beware, the most dangerous time is when you are young and inexperienced, because most of these cases occur outside regular working hours. So in this critical time period, which means you have an unstable and life-threatened patient, you are alone as a kind of a first line until your consultant on duty will arrive. You also can say, I'm not a traumatologist or surgeon, so it's not a problem for me, I will call the traumatologist. But be aware, there are sometimes you are forced to take care for these patients. For example, if you are the only doctor on duty in a small hospital, if you're working abroad, where ATLS is a must for the working in the ambulance or the emergency room, if you work for military projects abroad or in developing countries, or if you have multiple casualties or mass casualties. When you're an experienced senior traumatologist, you can say, oh, this is not a problem for me. I have seen and done everything. I will save him. But make sure it's right. When you're experienced, you can compensate a lot, even mistakes. But procedures can always be improved. Remember, you're only part of a team. And I think the last one is the most important one. You are responsible to train your young colleagues. So ATLS, and this is the summary, but be sure there are some slides coming. This is the summary of my talk. ATLS, I think it's a must for every young doctor, and at least the nice to have for experienced doctors. Because ATLS provides an easily remembered approach to the evaluation and treatment of injured patients for any provider, independent from your specialty, even under stress, anxiety, and intensity that accompanies that resuscitation process. Why? You may know that trauma is the leading cause of death in the first 4 decades of life in developed countries. So you can see the figures. Worldwide, we have more than 6 million trauma-related deaths per year. This means 9 per minute. And the most common cause are road traffic injuries. So annually, they cause more than 20 to 50 million significant injuries and more than 1 million deaths. This means a city like Munich or 10 times Larissa is killed every year on the road. And more than 90% of road traffic crashes occur in developing countries. There are various reasons, for example, non-compliance, and these are some figures from South Africa. You can imagine why. You can see. Nobody would be allowed to drive in this way in Germany, or in this case. But it also occurs in developed countries, for example, in the States. So in the States, up to now, we have 3.5 billion fatalities, which means 5 times the number of lives lost in all the US wars since 1776. And in the European Union, we have more than 30,000 fatalities annually. And for every fatality, remember, we have 4 permanently disabling injuries, 8 serious injuries, and more than 50 minor injuries. The crash causes, most of the time, human errors are involved: misjudging, driving dynamics, weather, distraction, alcohol, unexperienced, tiredness, so a lot of causes. And these are the costs, the economic costs for traffic crashes. So in Germany, 32.5 billion euros. 1.2% of the gross domestic product. These are the figures for Greece: 3.4 billion, 1.5 of GDP, and the global burden more than $500 billion a year. So, and this tendency is increasing. See the figures, okay? It's increasing. So for that, the World Health Organization made a global plan to stabilize and to reduce the forecast level of road traffic injuries and fatalities. And it's called the Decade of Action for Road Safety. And it's a roadmap for different sectoral national activities. And although we had a reduce in fatalities in Germany for several reasons, for example, speed limits, helmets, safety belts, or reduction of promille limits for blood and alcohol, there is still an increase in reducing the fatalities and to increase in the road safety. For example, you can see here in the last 20 years, we could reduce the number of fatalities more than 70%. And you also increase, you can see, reduction in more than 55%. So this multi-sectoral approach includes several pillars, for example, road safety management, safer roads and mobility, safer cars, safer road users, and so on. So we have an advance, and you know, all these information technologies for safety. For example, the blind spot detection or lane departure prevention, adaptive headlights, and so on, or driver assistance, or seatbelt and helmet wearing, reduce drinking and reduce speeding. And one of the most important things is the post-crash response. This focus on the need to shorten the time between the accident and the first aid, because time is life. Prognosis and outcome of severely injured patients, and we know that, depends directly on the rapid resuscitation and trauma care within the first minutes and hours following the injury, which we call the golden period of trauma. So we have 4 national activities. The first one is the automatic crash notification. This is an electronic system for automatic crash notification to the next central rescue. So by this, by an immediate initiation of the rescue chain, we can shorten the rescue time up to 50%. So we can save 2.5 lives per year, 26 billion euros a year in Europe. The second one is optimizing pre-hospital trauma care. That means that after we have a rapid assessment and treatment according to the priorities, so treat first what kills first, and this is PHTLS, pre-hospital trauma life support, but you also can train to students. And then you need a rapid transport to the next hospital, because the best care is given in the hospital. Remember that in the case if you have an acute abdominal bleeding, you need an operation. This means you have a decrease in survival time by 1% per minute. So you have to load and go, and you have to pay the patient to the next adequate hospital. The third activity is that we found to build up networks between different trauma centers. There are local trauma centers, regional and sub-regional, so different levels of care. And up to now we have more than 40 certified trauma networks covering more than 80% of Germany. And we have also these trauma networks at the borders with Belgium, Netherlands, Luxembourg, Switzerland and Austria. So these trauma networks means that we have different hospitals of different levels of care with defined standards, defined agreements, and the aim is that a maximum of 30 minutes from accident scene to admission to a trauma center. So we have defined standards in these single hospitals, which means, for example, for a sub-regional trauma center, which means the whole day, the whole year, we have to have all diagnostic and therapeutic possibilities. We should be ready to handle 2 polytrauma patients at the same time. We need trauma surgeons, we need general surgeons, neurosurgeons, and on. And what we also need is a special educational program, for example, HLS. So if you want to work in Germany, all physicians working in the emergency room, they need ATLS or a similar qualification. So the number of physicians trained in ATLS is continuously increasing. And up to now we are doing about 100 courses a year. I'm personally directing 10 of this in a year. So ATLS was introduced in 1978 by the American College of Surgeons. It's a standard training for doctors, and it provides one safe and reliable approach for the immediate treatment of injured patients for any provider, as I said. So we train every specialty, especially in the military doctors who go abroad for military projects abroad, and so it also provides a common language. So this is the concept. It emphasizes that injuries kills in certain reproducible time frames. So for example, a loss of airway kills more quickly than loss of breathing, and breathing more quickly than loss of blood. So please treat first what kills first. So you have an injury, then the first step is the primary surgery. This means resuscitation. So initial assessment and life-saving interventions. A, airway, B, breathing, C, circulation and hemorrhage control, D, disability, and E, exposure, which means temperature control. Then re-evaluation. The second is secondary survey. This is the head-to-toe evaluation, you all know, with a complete history and physical examination, re-evaluation, and finally definite care or transfer. So if we look back to this case, the question is, what are the priorities in management? And now it's relatively easy. Head injury, it's D. So maxillofacial trauma, it's an A problem. Thoracic trauma is B problem. This is a C problem. This is a C problem. This is secondary survey, so you have time enough. And this is also a C problem. So the priorities are simple. So first to address the maxillofacial trauma to ensure an airway, and then we have to address the pneumothorax, and then the rupture of the spleen, the pelvic fracture, and the right femur fracture. So that is easy. And you can learn this by an ATLS provider course. It's a 2-day course with an international certificate. You can see we have 16 providers, 1 director, 6 instructors, and we have pre-course tests, core content lectures, we have demonstrations, we have interactive case presentations, we have practical skill stations, post-course tests, and finally the exams. Now, you can see some ATLS impressions. You can see here surgical skills, for example. Here the practical skills. You have the final exams with some actresses and actors. And you know, finally, it's a very demanding and exhausting course, but also we have a lot of fun. So we should send best greetings to your international forum in Larissa by this provider course 2 weeks ago. This was the last I did in the military hospital in Ulm. So with over 1.5 million certified physicians in more than 60 countries worldwide, the ATLS concept is one of the most successful international education programs. So the question is, do ATLS really improve outcome of trauma patients, or is it a myth? So to be honest, there are only limited studies in the literature. There are no randomized controls before and after studies. So future research is mandatory. Although ATLS is initially constructed for rural hospitals in non-urban areas, where it shows to improve trauma care, and therefore ATLS training is recommended for all these emergency room physicians. For example, in Trinidad and Tobago, more and more physicians from developed countries registered for the ATLS courses. And there are some evaluations from Canada, highly recommended improved trauma care, Israel, high beneficial, the Netherlands, significantly improved, so significantly lower number of patients with inadequate management, and Germany, it's a prerequisite for participation in a trauma network. So we have very good evaluations and very positive feedback with a high recommendation. So this is the take-home message. Advanced trauma life support is a must for every young doctor, and this is a strong yes from my side, and also at least a nice to have for experienced doctors. But there's only one publication in literature telling that trauma patients treated by ATLS certified physicians died more often. And it comes from Greece. Fortunately not from Larissa, it's from Athens. And there are a lot of critical points. For example, you can see it here, and one is that they don't state if they compare individual surgeons before and after ATLS or the trauma team. So the German chapter of ATLS and the German Society for Trauma wrote in this, in an answering letter, we feel that this is a paper with a dangerous and unjustified message. We would be grateful if prestigious journals like Resuscitation protects readers from overestimating these results from this potentially flawed study. But ATLS can't destroy German-Greek friendship, because there's a possible explanation for Greek results. And the authors also state this in their conclusion. We believe that these findings must be seen in the context of the national healthcare system. There's considerable more room for improvement in our country. And this is what we have to state. ATLS provides a common language and a structure in trauma care, but what we need is a setting of an implemented trauma system. And this is the limit for ATLS, which is also seen in this publication from 2009. So if we have a severe traumatic injury during long-duration space flights, it's nice to have ATLS experience, but what you need is also a well-trained surgeon or surgical capability on board. And with this view to the future, I thank you all for your kind attention, and we all want to thank you all for saving lives. Thanks very much.
Thank you, Christof, for this very enthusiastic introduction, and thank you also very much for revealing this study. Of course, ATLS in Greece means that you don't have support from the door of the emergency department inwards.
Yeah.
So it's a problem of how you interpret that.
That's
That's for
right,
sure. Ευχαριστούμε. Υπάρχουν ερωτήσεις για τον ομιλητή, γιατί είμαστε στα όρια του χρόνου. Θυμίζω, παραλάβαμε 10 λεπτά καθυστέρηση στην αίθουσα. Okay, thank you. Thank you, Professor.
Thanks very much.
Thank you. είχαμε χώρο, φτιάξαμε κάτι. Ας πρέπει ένα 10 λεπτά, ένα τέταρτο καθυστέρηση. Αλλά, μας περιπτώσει, είναι στα όρια.
Θα το δείξω να το δείτε.
Συνεχίζουμε, δεν φεύγουμε. Φαίνεται ότι το ακροατήριο είναι πολύ κουρασμένο από το πρωί. Τι θέλει. Θα έρθει η Μαρία ή θα χτυπήσει έξω.
Αυτή τη στιγμή μπορείτε να παρακολουθήσετε στο Αμφιθέατρο Ιπποκράτης ομιλίες από δύο πολύ διακεκριμένους και εξαιρετικούς επιστήμονες που έχουν έρθει από την Αμερική, ειδικά για εμάς, και τους ευχαριστούμε πάρα πολύ για αυτή την τιμή που μας έκαναν.
Νομίζω πως μπορούμε να αρχίσουμε. Είναι για μένα πολύ μεγάλη χαρά να προεδρεύσω δύο εξαιρετικούς επιστήμονες και φίλους του Πανεπιστημίου που έχουν έρθει για το φόρουμ αυτού του συνεδρίου. Θα ήθελα να δώσω το λόγο στον κύριο Sadis Matalon. Ο κύριος Matalon είναι επίτιμος διδάκτορας του Πανεπιστημίου μας, του ιατρικού μας τμήματος, και η κυρία Riesenberg θα μας μιλήσει για την ιατρική εκπαίδευση. Νομίζω ότι κάναν διάλειμμα κάποιοι, αρκετοί, αλλά νομίζω ότι αν αρχίσει Σάντι θα έρθουν. Ευχαριστώ πάρα πολύ που είσαι μαζί μας. Ο κύριος Μάταλον μιλάει πολύ καλά ελληνικά, αλλά νομίζω μάλλον τη διάλεξη θα την κάνουμε στα αγγλικά ή όχι.
Αγγλικά, ναι.
Αγγλικά. Ωραία.
Ευχαριστώ πάρα πολύ, Κώστα μου. Ευχαριστώ να έρθουμε εδώ πέρα. Είναι μεγάλη μου τιμή και με συγχωρείτε που πρέπει να τα έχω πω στα αγγλικά. Αλλά, now, what I'm going to tell you is what in the United States we call from the bed to the bedside. In other words, how we can use clinical knowledge to make new discoveries, and how we can translate these new discoveries back then to the United States. Now, before I start, I would like to thank all of the people in my laboratory who do all of the work that I'm going to present to you. And in addition to, I want to show you two of my most favorite trainees that they're both from Larissa. You recognize them both, Dr. Philippidis and Sotirios Zarogiannis. They both were in my laboratory and they did great work, and I'm very, very grateful to them. And I'm sorry Sotirios cannot be here today. Now, the whole story started back in 1967 when two physicians at the University of Colorado described for the first time what we call now adult respiratory distress syndrome. At the time, they really did not exactly know what they were dealing with, except they found, they simply wrote a report, a clinical report to Lancet, which of course is one of the most famous journals in the world, and they referred to patients that had dyspnea, tachypnea, cyanosis, and the cyanosis could not be cured by exposing them to oxygen. They had decreased lung compliance and diffuse alveolar infiltration as seen here in the chest X-ray. And as you can see really from the X-ray, the disease progressed over time and became much worse at 18 hours later. This is actually something that was seen in the battlefield. At the time, the United States was fighting the Vietnam War. And the military surgeons noticed that young soldiers that had a bullet wound to the leg or sepsis did fine for a while, but when they were evacuated to a tertiary center, they developed essentially a wet lung and died from fluid in their lungs. So what we know right now is that this particular syndrome, adult respiratory distress syndrome, is caused by a number of different conditions, including pneumonia, aspiration of abdominal contents, inhalation of oxidant gases like smoke, chlorine, etc., pulmonary contusions, or it can be caused indirectly as following, for example, severe trauma or fracture of the femur or sepsis. So the thing that we know right now is there are different ways to characterize ARDS. And according to the most recent definition, the Berlin definition of 2012, it is characterized as the respiratory failure, which cannot explain by cardiogenic pulmonary edema or volume overload during the treatment of the patient. And as you can see on the right, from the now very famous article by Dr. Mathey at the New England Journal of Medicine, you can see that on the left we have the normal lung, and on the right we have the ARDS lung. And what you can see right away that there is fluid in the lungs. There are a number of inflammatory cells. And actually, the endothelium has become ruptured, allowing proteins to come from the blood into the alveolar space. We have different definitions, and that you will encounter when you do a residency with Dr. Gouroulianis in pulmonary medicine. Now, you know, it is amazing. We have spent 25 years trying to find a treatment for ARDS. And the National Institute of Health has spent billions of dollars. And we had one clinical study after another clinical study, and nothing really worked. I will not really go through them, but you know, most recently we thought statins may make a difference, but unfortunately they don't. Now, the only thing that makes a difference is how we ventilate these patients. All of these patients are in mechanical ventilators, and what we have found right now, that if you ventilate the patients with a low tidal volume, that is 6 milligrams per kilogram instead of the traditional 12 milligrams per kilogram, we have decreased mortality significantly. So, for that reason, there is always new research going on to find out a new way to treat ARDS. Now, this is the bedside. Now we're going to go back to the bench. And in order to find new treatments for ARDS, we must create animal models. And one of the animal models I'm going to describe to you is when we expose animals to chlorine and bromine, and the relevance of that has been shown recently. As you can see, the chlorine has been used extensively in the battlefield in Syria, and we have in the United States many, many accidents every day when chlorine is transported. You can see here another toxic gas, bromine, and a train carrying bromine, and during an accident, that vapor you see is a very toxic gas, and that can make people very, very sick. Bromine is used extensively in the industry, and it is being transported from one place to the other by train, and of course, a lot of accidents happen. Now, what we're going to do is to try to find a model of ARDS. We take mice, as you can see this little mouse in the chamber, and we expose them to bromine for 30 minutes, and then we return them to room air. Now, the animals become, once you let them back to room air, they appear fine, but if you follow them over a period of time, you see they're going to die. And essentially, that is what happened with ARDS. Initially, you may not see the injury, but you can see the injury later on. And what is really important, what I'm going to tell you, it was really done by a medical student like you, about the third year of medical school, who spent a lot of time in my laboratory. So we take this particular model where we expose animals to 600 ppm of bromine for 30 minutes. We return them to room air, and you can see about 50% of them die within 5 days. And if you look at their lung, they really look like liver. They are full of fluid, and they have all the symptoms of ARDS. Now, we went through a lot trying to understand what is causing that. And what I'm going to tell you right now may seem very paradoxical to you. If I point at any medical student and ask them, what do red blood cells do? Well, you're going to tell me, I hope, that they have hemoglobin and they transport oxygen and carbon dioxide. That's absolutely correct. And hemoglobin inside the red blood cell is absolutely essential for life. However, in a number of diseases, what happens, hemoglobin, the red blood cells are going to rupture, and hemoglobin leaves the red blood cell and comes out essentially in the interstitial space or inside the plasma. Hemoglobin then can break down to free heme, and that's a real problem in a number of diseases, in addition to ARDS, like in sickle cell disease or in dialysis, and especially when we store blood in order to give it later on to patients. Now, the problem is that either free hemoglobin or free heme is very dangerous. It can create essentially reactive oxygen species, free radicals, that can damage every tissue on the body. So, while hemoglobin inside the red blood cell is a wonderful thing and absolutely essential for life, hemoglobin outside the red blood cell is very dangerous and can cause a lot of problems. Let me show you some examples. So, what we did for this type of experiments, first of all, we wanted to see, is there free hemoglobin in the alveolar space, in the blood, and the lung tissue? So we took mice, again, we exposed them to bromine for 30 minutes, we bring them back to room air, and 24 hours later we sacrifice them. Then we do something called a bronchoalveolar lavage, again, something we do in patients as well, sometimes to diagnose what kind of pneumonia they have. And once we have the BAL, then we measure free heme and hemoglobin in the bronchoalveolar lavage. And as you can see over here, there is animals breathing air, there is animals breathing bromine, and there is considerable amount of free heme, both in the alveolar space, in the plasma, and in the lung tissue when you chop it up. Well, this is well and good. Now we know something that may be causing the injury. The question is, how do we prove that this is the case, and what kind of a therapy can we offer? Well, there is something called hemopexin, which is the primary specific carrier of plasma heme. And what it can happen, hemopexin will bind free heme, and then it will transport itself to the liver, it will bind to the receptors in various cells, and then it's going to be destroyed inside the lysosome over here. So what we did is the following. We took animals, exposed them to bromine, returned them to room air, and 1 hour later we gave them an intramuscular injection of hemopexin, something like we can do in a human. Now you can see these animals right now that receive hemopexin do not have increased level of heme in the BAL, or in the lung, or in the plasma, or in the whole lung. Well, we have scavenged the free heme. The question is now, how do we know that it made a difference in the animal? Well, again, in looking at ARDS, what is the diagnostic way of ARDS? Is to look at the amount of protein in the bronchoalveolar lavage. This is the amount. Okay, you cannot get protein in the bronchoalveolar lavage because the alveolar epithelium is ordinarily very, very tight. Now, what we did then is we tried to measure the protein in the BAL at animals that received hemopexin and animals that didn't. And as you can see over here, after bromine, there is a huge amount of protein in the BAL that's indicative of the presence of ARDS and severe injury to the alveolar epithelium. However, when we gave hemopexin, we were able to reduce the amount of protein in the BAL and reduce the amount of inflammation, and more important, actually, the number of neutrophils in the BAL decreased significantly. So we have the possibility here of being able to decrease injury, but one of the things that we really would like to do all the time is when we try to promote a new drug, is to ask, does it make any difference in survival? It's well and good to decrease injury, but now what we did again, we exposed animals to bromine, brought them back to room air, and then we gave them a single dose of hemopexin an hour later, and we let them be. You can see animals that received saline died, and 50% of them were dead by 5 days. However, after a single dose of hemopexin, right now the animals survive much longer. So that's very, very encouraging. And this may lead us to think that this may be a treatment for a number of diseases. Now, one of the things that we find in patients with ARDS is, especially when they are on a mechanical ventilator, 3 or 4 days after being mechanically ventilated, they develop a number of respiratory infections. And I am showing you two particular articles, one of them written by Despina Koulenti, a very famous Greek. That shows that patients with ARDS on mechanical ventilators suffer from respiratory infections, and the most common respiratory infection is Pseudomonas aeruginosa. So we wanted to know if whether we give hemopexin, we can also prevent respiratory infections. So we do the following. We take mice, we expose them to bromine, which is the equivalent of ARDS, and then sometime later, at day 4, we give an intratracheal instillation of Pseudomonas aeruginosa, and then we sacrifice them a day later. Now, this is the best example to show you that animals breathing air and given Pseudomonas aeruginosa are able to totally clear the pathogens. Our immunity kicks in and we kill all the Pseudomonas we are going to breathe. However, animals with ARDS that they had, and then that were given Pseudomonas, a day later, notice how many colonies we have in the lung. And by doing PCR, we were able to show this was indeed Pseudomonas. Now, the next experiment we did then is, again, we made animals with ARDS, then we gave them hemopexin an hour later, 4 days later we gave Pseudomonas, and then we sacrificed them a day later. Now, as you can see from here, we have animals that were given air and Pseudomonas. Again, you don't see any colonies. You see a huge amount of colonies when you have animals with ARDS that were given Pseudomonas. And here, when they received hemopexin, well, at this particular case, you don't see any colonies at all. So, now, how about, did they make any difference again in the animal? Well, when animals are given air, and then where they're exposed to bromine, and then given Pseudomonas aeruginosa, they have a significant amount of protein. However, if you give them hemopexin, we are able to decrease the amount of protein in the BAL and the amount of the total cells in the BAL, as well as the number of neutrophils in the BAL. Now, where do we go from here? Now, first of all, I understand that you are you're going to be medical doctors. You're going to take care of patients. Believe me, that's what we do in the United States as well. Why do you want to think about doing research? Why is scientific research important to you? Well, for two important reasons. Number one, during your professional career, you're going to be exposed to concepts and ideas that you did not learn during your practice. You continuously have to learn. You have to be able to evaluate what is written, for example, in a scientific journal and say, that is good for my patient, or no, this is nonsense and I'm not going to use it, because everybody is trying to promote a therapy. Okay? The other thing is that it's exciting. The difference between just being a doctor and being a doctor scientist is you can drive a car, but if the car breaks down, you don't know what to do about it. If you are a doctor scientist, you can fix the car as well. Now, where do I go now with the new drug that I have, the hemopexin? It will take about 10 years and about $1 billion to be able to convince anybody to use that in the clinic. We have a lot of work to do, but it's exciting. We have a potential treatment, and we're going to have, first of all, do trials to show that hemopexin is safe in humans, and then from there on, that it has an effect. Well, I'm going to close by thanking again Dr. Gourgoulianis, and thank you, the organizer, for allowing me to talk. It's a great pleasure, and as we say in Greek, σας ευχαριστώ πάρα πολύ.
Κύριε Γουργουλιάνη, ανοίξτε το μικρόφωνο και το ένα το κουμπάκι μην το πατάτε γιατί ακυρώνει όλα τα μικρόφωνα.
Ωραία. Any questions? Ξέρω ότι ο καθηγητής, ο κύριος Σίμος, δουλεύει με αυτό. Και Γιώργο, κάποια ερώτηση για το...
Thank you very much. I do have a question. I was wondering whether dialysis would help patients by removing the ΕΣΦΙΕ in the situation?
Thank you, Sim. Thank you very much for the very important questions. And indeed, dialysis is another approach, and actually we do that in a number of cases, because this is true not only in ARDS, but we also see it in sickle cell anemia, for example, or cases of trauma. We find that heme is also the major mediator of injury, and dialysis can take care of that. That you're absolutely correct.
Υπάρχει άλλη ερώτηση για τον...
I'm tempted to... Θα ήθελα να τους ερωτήσω εγώ μια ερώτηση.
Ωραία. In Greek or in English?
Well, να τους πω μια ερώτηση. Εσύ κύριε εκεί πέρα, ναι, εσείς. Ναι, παρακαλώ. Πώς σας λέγεται, πώς λέγεστε? Αλέξανδρος. Τι είσαι, Αλέξανδρο, είναι σε πρώτο έτης. Μόλις... Ναι, μόλις... Πες μου, ξέρεις από την hemoglobin, τι θα πει hemoglobin? Όχι. Δεν το έχετε μάθει ακόμα. Εντάξει, είσαι μικρός. Θα το μάθεις. Εντάξει.
Okay. Ευχαριστούμε πάρα πολύ. Next speaker is Professor Lian Riesenberg, Department of Anesthesiology and Preoperative Medicine. Professor Riesenberg is a full-time medical educator, works for the anesthesiology and perioperative medicine residency program. And the title of her lecture is about research.
About what?
About research.
Patient handoffs.
Okay.
Research. Patient handoffs.
Okay.
Research, sure.
Research.
Sure. So, Herete, Kalispera. Ime Americanida, Catalaveno Ligo Alenica. So I have no idea how he introduced me. I am a professor and the Associate Director of Education. I started out in nursing. I'm a registered nurse. I also have a bachelor's in psychology and a master's in healthcare administration, and my PhD is in higher education. I've worked in medical education for almost 30 years. So undergraduate and graduate medical education is what I've done. I'm very interested in patient handoffs, a place where very little research has been done, very little high-quality research. And so that is what I'm going to talk to you about today. I have no conflicts of interest, and I actually have received funding from several sources, all of which are from the United States, and none of which conflict with anything that I will be talking about today. I plan to describe the research evidence available to date that's related to patient handoffs and to introduce ideas for future research. And I hope for some discussion. I, like my husband, will actually ask you questions if you don't ask me questions. Definition of a patient handoff. It is a process of transferring primary authority and responsibility for providing clinical care to a patient from one caregiver to another caregiver. And here I'm talking, in the United States we call them handoffs, handovers, and sign-outs sometimes. There are a number of other words that we use. I'm not sure what you use in Greece. But I'm going to be talking about three different kinds of handoffs. Transitions of care, that's the transition of a patient from one location to another, which would happen when a patient finishes surgery and goes to the post-anesthesia care unit, for instance, or from the emergency department to the inpatient arena. Shift-to-shift handoffs when providers hand off patients to the next provider. And then duty relief when you need to go to lunch or dinner. Whoa. Very good. Okay, so there are different kinds of handoffs.
Συγγνώμη, αλλά έχουμε γενική διακοπή. Εδώ λειτουργούμε για κάνα τέταρτο, μισό λεπτό.
Oh, okay. Okay, well, I don't need lights. So, they're... It's better. Oh, it's perfect. This is awesome. So there are different kinds of handoff settings. There's the ward, there's procedure areas, surgical areas. There are intra and interdepartmental handoffs, and intra and interprofessional handoffs. For instance, in the United States, our anesthesia residents hand off the patient from surgery to the post-anesthesia care unit, and they hand them off to nurses. So interprofessional. Healthcare in the United States, and I'm sure here in Greece as well, is very complex. And it's very difficult to maintain high reliability and maintain safety of patients when things get complicated and when we hurry. I'm going to briefly talk about the timeline for the United States for handoffs research. Much of this is not relevant to you, but one seminal thing happened in 1984. A young lady, she was 18 years old, Libby Zion, was admitted to a hospital for viral syndrome. She came in the evening to the emergency department, and she was agitated. She also had, as I said, symptoms of a viral infection. She was seen by an intern, that's a first-year resident, and an upper-level resident, and they decided to admit her for observation, and they gave her a little sedative to help her calm down a little bit. Unfortunately, things did not go well from there on. The intern went to bed to get some sleep. They'd both been working for over 18 hours. And the resident went on to see more patients. And then about 5:30 in the morning, the intern was called because the patient was more agitated. And without seeing the patient, he ordered both chemical and physical restraints. By 6:30, she had a cardiac arrest and died. She was otherwise healthy. There were some things about her that they didn't know, of course. She had been prescribed several antibiotics over the course of the last few weeks from different doctors. She was taking illegal drugs. She was also drinking a lot of alcohol. And so she was pretty high when she came to the hospital. And then they added in some extra sedatives, and those things interacted. Also, her father was a lawyer, and he was a writer for the New York Times. And he was very, of course, as any parent would be, very distressed. But because he was a lawyer and he had a lot of power, he was able to write a lot of articles about this and bring a lot of attention legally to the case. And because of that, New York State, she died in New York, New York State implemented duty hours restrictions for residents in 1989. And actually, these hours might sound a little weird to you because our residents are restricted to working no more than 80 hours a week, averaged over 4 weeks. And I understand that you work 48 hours a week. So we work quite a bit more. But at the time this happened, our residents were actually working somewhere around 120 hours a week. Then our accrediting body, the ACGME, which accredits all graduate medical education, implemented duty hours in 2003. The most important thing is in 2006, the Joint Commission in the United States is the body that accredits all hospitals, outpatient facilities, nursing homes. They accredit everything, and they look at us every year, and everybody is very afraid of them. In 2006, they implemented what they called a National Patient Safety Goal to improve handoffs. And in that National Patient Safety Goal, they said that handoffs now had to be standardized. So now we've got this rule in 2006, we have to standardize handoffs. We don't really have any research to tell us how to do that, but that was the rule. And then in 2013, the ACGME, again, the accrediting body for graduate medical education, implemented even more stringent duty hours, but they also implemented something called the Next Accreditation System, and it has 6 focus areas, one of which is handoffs. So every time we get accredited, and we get visited about every 18 months, one of the things they look at is the handoffs that are being given by both our medical students and our residents. So why all the fuss? Why do we care? Well, I'm going to tell you a story, and I'm going to ask you to tell me what happened. This is a 52-year-old white male. He actually was climbing on a ladder to fix something on his roof. He fell. He needs surgery for open reduction of a proximal right humerus fracture. There are a couple of things that I didn't say there. He's also obese, and he has sleep apnea. The anesthesiologist, who is an upper year resident, in anesthesia, we train our residents for 4 years. An upper year resident, very, very skilled in intubation, has some difficulty intubating the patient, requiring multiple attempts. Thus, there's a little bit of airway trauma. So then the team discusses this at the beginning of the case, and the team decides we should keep this patient intubated a little bit longer than usual. We'll send him to the post-anesthesia care unit intubated, just to make sure we protect the airway. Surgery is a little bit more complicated than they think. It's a very compound, complex fracture, and takes longer than they think, but otherwise there's no complications. Nothing bad happens, except it takes a long time. The resident, who is the anesthesiologist, transports the patient to our post-anesthesia care unit, where he will hand off the patient to a nurse. Once there, he receives a page from our emergency department saying that he has a trauma patient that needs to be intubated, and he must be there right away. In his hurry to leave to get to the emergency department and take care of another responsibility, he gives a very brief handoff and does not include anything about the difficult airway. What happens next? Yes?
Probably the doctor who receives that patient doesn't know about his problem with the airway.
Right. And so what will that doctor do?
He will probably neglect that problem.
Yes? Yeah, very good. Excellent. He will forget the problem. The patient is intubated, so what's he going to do now? Honestly, I'm comfortable with silence, so I could stand here for a long time. He will extubate the patient, of course. We're going to move things along because we need to get this patient out of the post-anesthesia care unit. The patient usually is extubated in the OR. He wasn't extubated. Let's get him extubated. And then what's going to happen? He's going to have trouble breathing. And we're going to need to intubate him again. And the person who intubates him is going to have even more trouble than the experienced resident in the beginning, because now we have a patient with lots of complications. He's obese. He has sleep apnea. His airway is traumatized. It was difficult in the beginning, so now it's going to be very difficult. And it's going to become an emergent airway, and we'll have to do a tracheostomy on this patient, all because of the handoff. So there are lots of things we know about handoff errors. We know that 80% of malpractice suits have some kind of communication error in them, and as a causative factor. In 134 consecutive postoperative pediatric ICU patients, handoffs, 100%, every single one of them had miscommunications. These were tape recorded and videoed. And they all had errors, either omission or commission. They had added information that didn't belong, and they had errors in the information that was actually conveyed. Patients with acute ischemic stroke, 366 consecutive patients in an emergency department. They did a study where they looked at those who were present at shift change and those who were not present at shift change. And here, it's important to know that they controlled for all the confounding variables. Thus, they controlled for how long the patient was in the emergency department. They controlled for age, sex, race, all the things that you think might make a difference. And what they found is patients who were present at the change of shift, that one variable, increased their risk of having pneumonia in the hospital by 5-fold. And in the field that I'm working in, anesthesia providers, we looked at 139,000 adult surgical patients. And we looked at how many times they had a transition of care, a handoff to another provider during surgery. And they controlled for everything: age, sex, race, their ASA status, the procedure, the length of time they were in surgery. All of those things were controlled. And what happened was we found that the number of handoffs increased their in-hospital morbidity and mortality. And it was incrementally increased as the number of handoffs increased. So when we went from 0, 1, 2, 3, and 4, we went from 8.8 to 11 to 14 to 17 and 21% increase in hospital mortality and morbidity. Handoffs are really important. So my journey is a little bit serendipitous, a little bit of luck played in here. I actually, in 2008, was in a national group that had decided to improve patient outcomes through graduate medical education. And this group had 19 different hospitals with representatives, and we decided that we were going to focus on a few key areas, and one of them was handoffs. And I raised my hand and said, I'll do some research, some background research on handoffs, so the rest of the institutions don't have to do it. I'll do it myself. And when I went back to work, along came a student who'd just gotten her bachelor's degree, and she graduated 6 months early, but her parents had paid for her apartment. So she was going to stay. She was going to a graduate program in September. She needed to work, and she didn't need to be paid, which is an awesome set of circumstances. So I put her to work working with me on handoffs, and actually she got many publications out of this work. We started out with physician handoffs, and we looked at the literature from 1987 to 2008. We did systematic reviews of the literature. And we found 46 articles, only 18 of which were research articles, and only a third of those used a measure of handoff effectiveness. So what we did was we said there's very little research that's been done to identify best practices, and there is a high need for high-quality handoff studies focused on systems factors, human performance, and effectiveness. We looked at handoff mnemonics. We did a systematic review of the literature on handoff mnemonics, and since then I've also published editorial. And during that time period, 1987 to 2012, we found 57 articles published with 36 different handoff mnemonics. A mnemonic is an aid to help you remember how to hand off, right? Mnemonics are aids for everything, right? We don't need 36 mnemonics. I can't imagine the situation where we need actually 36 different mnemonics for handoffs. So a lot of mnemonics are being published, and since 2012, even more have been published. Unfortunately, the studies are not scientifically rigorous, and we don't know which of these handoffs are actually effective. Since then, I've done a number of other systematic reviews of the handoffs literature, 5 of them, one on nursing, one on bedside report, doing the report at the bedside. One was on electronic tools that are used to help improve patient handoffs. One was focused completely on patient outcomes. And then the final one that we've published recently is on feedback and evaluation tools used to improve learners' feedback or learners' handoff techniques. And of course, our conclusions are very much similar to other studies that we've done. We need high-quality studies with a comparison control group. Many of these are very small studies locally done at one department, and they do not include a comparison or control group. We still have not identified best practices. And we have now begun to say we need to have increased funding directed at understanding how to improve handoffs. So what else do we know? A wealth of information creates a poverty of attention. We need flexible standardization. We can't just standardize handoffs. You need a balance between too much information, so don't start with everything you know about the patient, the entire history, medical, social, and all your physical findings. You want a very focused information when you give your handoff. And we don't want too little information, which is what happened with the patient that was extubated in the PACU. And it has to be adapted to the current situation. So if in the United States, many of our residents may be in a situation where they hand off 15 patients. If you have 15 patients, one or two of them are critically ill and the rest are pretty stable, of course you're going to focus more time on the critically ill patients and less time on the patients that are stable. What are the functions of handoffs? We have actually studied that, and we know that one thing is actually information transfer. Also information processing. So as the person gives the information and receives the information, they are processing that information. There's a transfer of responsibility and authority. This is a time for shared decision making. It's an opportunity for the off-going practitioner and the ongoing practitioner to make some decisions about what they want to do in the future, and to co-construct what we call a shared mental model, which is very important to high reliability organizations. Resilience. That is the ability of anything that happens in healthcare to fix a problem. Handoffs actually offer us the opportunity to fix problems that are ongoing. It's a social interaction as well. It's a time for team building, and it's a time for learning. So when an upper level resident is handing off to an intern, or a faculty member is handing off to a resident, it's an opportunity for teaching and learning to occur. There are phases of a handoff. First, we have to do the pre-work, getting ready for giving the handoff. We give the handoff. But giving the handoff is not enough. We need to make sure that information was actually received. And then there's the transfer of responsibility of the patients. And I'm going to talk to you about something that I think is really fascinating, cognitive load. Our working memory or short-term memory, and short-term memory is what you use when you give a handoff, holds only about 4 to 7 elements, plus or minus 2. And there's some very interesting research that's been done by Young and colleagues that breaks down subtypes of short-term memory into intrinsic load, extrinsic load, and germane load. The intrinsic load is the amount of information, the elements, the number of patients. That's the intrinsic load. The extrinsic load is actually the physical environment. Is it noisy? Is it too dark? Is it too bright? Are there lots of people talking about are you getting lots of interruptions, getting paged? And also, how are you feeling? Are you tired? Are you frustrated? Are you stressed? Are you sick? And then there's the germane load, and the germane load is the effort that is used to compare and contrast the information you're receiving with what you already know, and to activate your prior knowledge and then try to figure out if there's something here to learn. So, what we know is that different loads, intrinsic, extrinsic, and germane, interact with one another, and that the learner's knowledge and the case complexity interact to affect handoff accuracy and cognitive load. Thus, what I'm saying here is, if the learner has very little knowledge and the cognitive load is high, the case complexity is high, then of course the handoff accuracy is going to deteriorate. Inversely, if the learner is very experienced and knows a great deal and the case is not very complex, then the handoff should be accurate and the cognitive load will be relatively minor. So what do we have to do to fix that? Well, we really ought to be using some kind of protocol or mnemonic to help us remember how to give and receive handoffs. We should be monitoring the number of patients in a panel, in the number of patients that are being handed off. We should monitor the residents' experience and medical students' experience in relation to the size of the panel, and we should train medical students and residents in what is called attention awareness. You should know what you're paying attention to. Right now, I'm paying attention to a couple of people who are passing phones and talking to each other. And what I really need to be paying attention to is my talk, right? So we need to be aware of what is it that's captured your attention. And we need to be able to harness that. And when you're giving a handoff, really focus your attention. And this also involves active listening and slowing down your thinking. So there are cognitive biases that are important to handoffs. There's an egocentric heuristic, and that means that you overestimate the clarity and effectiveness of what you're communicating. So right now, I think I'm doing a pretty good job. And so I think I'm communicating very effectively because I have egocentric heuristic about myself. There's a false consensus effect that happens. Speaker believes that the listener shares the same view of the situation if the listener doesn't say anything. Also, there's something called diagnosis momentum. So, if you know the person you're receiving the handoff from, and you believe that they are very intelligent, they have high skill level, you're more likely to just listen to what they've said and accept the diagnosis that they've given you, and not question it. And then finally, there's hindsight and outcome bias. So every week in anesthesia, we do a continuous quality improvement conference. And in that conference, we talk about cases where something went wrong or something almost went wrong. It's very much like M&M, Morbidity Mortality Conference, only here we talk about all the system issues that allowed this thing to happen or almost happen, and we don't blame people. We don't talk about who did it. We talk about how this happened, or nearly happened. And what happens is if there was a handoff during a case that has a problem, we're very likely to attribute some of the problem with the handoff, because in hindsight we see that there was a negative outcome, then we're much more likely to attribute negative aspects to the things that happened during the case. I mentioned resilience. Handoffs are an opportunity for us to fix problems. Unfortunately, that is it's very hard to study resilience, because when a problem is identified and fixed, there's no measure of that. There's no actual artifact that's left behind when you fix problems. But handoffs actually do allow us to fix patient care problems. Physicians are constantly monitoring, adapting to, and acting on handoff failures and to prevent adverse events. What do we know about what we're teaching medical students? And I don't know what you teach in Greece, but I would be surprised if you do a better job than we do. Because I think it's across medicine, across nursing in the United States, we do just about the same thing. We use sort of an apprentice model. You go, you watch upper level people give handoffs, and then you give handoffs. So a systematic review of the literature was done in 2010. And what they found was that of curriculum, handoff curriculum, they found only 10 studies, and only one of them even looked at process outcomes. Process outcomes are how the handoff is given, not the results of the handoff. Generally, they were of poor methodological quality, and since then, my team has been monitoring curriculum, handoff curriculum articles, and we found about 30 more articles since then. Less than half of them included a process outcome measure, and of 30 articles, only one of them looked at patient outcomes. And now patient outcomes are why we started worrying about handoffs, because bad things were happening, and that's what we should be studying. Handoff readiness. In the United States, our medical students do 4 years of undergraduate, then 4 years of medical school, and then they go to residency. On the first day of residency, they are expected to hand off patients effectively, efficiently, and safely. Entering interns, prior education and preparation for handoffs. So, in one study done in 2005, less than 10% of medical schools formally taught handoff education. In 2010, it was up to 30% for written and 23% for verbal. In 2012, 35%. 2014, we're down to 24%. I think that represents regional variation in the United States, and it's probably somewhere between 24 and 35% of medical students are actually being taught about how to give effective handoffs. Yet, 83% of internal medicine residents, now this is a sample of over 20,000 internal medicine residents, ranked communication at care transitions as one of the top 3 skills required of an entering resident. When I do new resident orientation, one of the things that I hear almost uniformly is, "I'm afraid I will kill someone tomorrow." Our residents are afraid that they're going to kill someone, and all we've done is give them a didactic lecture on handoffs. Handoffs, I would posit, are a skill, and we cannot teach skills through lectures. That's a beginning point to give a lecture, but you have to practice handoffs, you have to receive feedback on your handoffs in order to get really good at them. Some people just magically get it right away, but many people do not. Where do we go from here? Well, we need to improve study design of handoffs, increase sample sizes. Most of the studies that have been done in one institution, one department, and are small scale and short term. So if you implement something and then you watch the residents to see how the handoffs are going, that's called the Hawthorne effect, and you're probably going to improve handoffs. But what happens a year later? That's what's really important. After you stop watching, how are the handoffs being done? We should be looking at different types of methodological studies, quantitative, qualitative, mixed methods with quantitative and qualitative, and quality improvement, which is a new kind of study that we're doing in the United States. There are different measures of handoffs, and Donna Bedian in 1966 first talked to us about these different kinds of handoffs. They are looking at the structure. One of them would be, where is the handoff given? Is there a space that's dedicated to handoffs? Is it noisy? Are there lots of interruptions? Another is process. So how are the handoffs being given? What are the behaviors that are happening during the handoff? And finally, outcomes like length of stay and mortality, because patient outcomes are what we care about and what got us started on this journey of standardized handoffs in the United States. There are different ways that we can measure handoffs in a time period. So immediately we can look at adverse events. Intermediately we can look at in-hospital mortality. And delayed we can look at 30-day mortality. I have many people to thank for this lecture. I have a team. Right now, I had 5 medical students working on this project. Jessica Light, who started with me back in 2008. I have a huge number of medical students who are working with me now, and residents who are not listed here. Questions?
Thanks.
Congratulations on this wonderful talk. I would like to... Thank you. A nice, humble suggestion and a question. The humble suggestion is that the term handoff is not as euphonic as another Greek word that you can use in the future called metaphora, transfer. So you have used other words, Greek egocentric, mnemonics that are wonderful. So handoffs remind me, handcuffs, it's not as euphonic as metaphora. So think about that. Metaphora. Your husband will tell you how to use it. It's so nice. The other question is, you and others have blamed since 1984 the doctor that didn't go back, the system, and the patient died, the patient suffered. But in the United States, that you demonstrate as being a place that things are in order and so forth, you haven't done anything about you haven't blamed the patient. So you describe that lady as being drunk, under narcotics, came and died. And everybody blamed the doctors, the nurses, the system. Now, you did mention the father, a lawyer, because he was a lawyer, caused all that trouble. And no medical American institution has attacked the lawyers for this catastrophe that have caused to American and medicine, especially surgery. A recent study called the second death after complication, that the second victim, correct? Yeah, right. So the question is, are you planning to stop dealing with prevention between nurses, young surgeon residents, and try to find out and protect us from the patient and the lawyers?
Please open the microphone. Thank you.
Ευχαριστώ. So, very complex question, but I'll answer one part of it. In our department, we have a very heavy reliance on continuous quality improvement. We meet once a week and we talk about the system and what the system allowed to happen, not the people, not the person who made the mistake, I said. And we actually have education on the second victim. We talk very much about something called the Swiss cheese model and how we draw an arrow through all the holes in the system that allowed this happen. And at the point of the arrow is one patient and usually one provider who are the victims of this error. But the system allowed many things to happen. And yes, in Libby Zion's case, we didn't know, the residents didn't know at the time that she was taking many medications, many drugs, and that those would, of course, affect the outcome. We are in the midst of having malpractice reform in the United States, which will help some. But it's a problem for us. But I teach quality and patient safety. One of my certificates is I'm certified in medical quality from the American Board of Medical Quality, and I actually work with our medical students and residents. I teach them how to understand improving quality without blaming the physician. And so maybe you'll invite me back to speak about that later, some other time. Thank you.
Okay. Thanks again. Τώρα είναι ώρα για χειρουργική, κύριε Τεπετέ.